we're going to start anywhere, we have to know where we want to end up, right? So how do treatment goals differ, if at all, by the subtype and severity of the disease?
Well, when we talk about, the burden of hemophilia, mostly we're thinking about severe hemophilia, which again presents with spontaneous bleeding at a young age. Actually, as it turns out, if the level of residual clotting factor activity exceeds 1%, which is the threshold above which you no longer are considered to have a severe hemophilia, but instead moderate hemophilia, and then above 5% mild hemophilia, spontaneous bleeding isn't really, that common. It can happen. But mostly it's experienced with trauma or major surgery, for instance. And so it's really the patients with severe hemophilia who are looking at using prophylaxis from a very young age. And then that's where we talk about the high cost over a lifetime.
I just want to pause for a moment, because the number, just as a physician, the number you quoted is simply astounding. It's breathtaking.
Yeah.
If you have 1%,
right,
5%, you're okay.
To me, that means that, for instance, factor VIII and factor IX are very, very important proteins. So nature ensured that we have a whole lot of it around. Yes, over 1% actually is the target for a trough level for prophylaxis. You want to keep that level from ever falling below 1%. If a child wants to play, contact sports or whatever, then that's going to have to change and be higher. But for prevention of spontaneous bleeding, that's the threshold.
But that simultaneously answers one question you had about trough levels. But to me, as someone who's been in the doctor trade for a long time, looking at the biology of this, 1% is so small. And that's all it takes. This is a well-designed machine. It takes a lot to break it.
Seems like it, yeah.
Yeah, it's pretty cool. What are the difference in treatment expectations then between patients and providers? You want to keep it above 1% or 5%. What do the patients want?
Well, I think the patients want to, and the parents of patients, from the pediatric perspective, want to either live normal lives or have their children live, as normal lives as possible. That's going to be translated into functional outcomes. And what intersects with that is the ease of administration of the replacement protein. As you mentioned, this is an intravenous therapy. You got to place an IV, mix it up. If you have to do that fewer times per week to achieve the same result, then that would seem to be an improvement. And certainly the field is moving that way with regard to longer acting proteins.
So help me out. There's treatment versus prophylaxis.
Yes.
What are we talking about here?
Well, prophylaxis again refers to prevention of bleeding episodes, and for patients with severe hemophilia, it typically constitutes administration of intravenous doses of replacement clotting factor proteins at least once a week, but for children, mostly twice a week up to every other day.
And I hear the phrase primary and secondary prophylaxis.
Yes.
What does that mean?
Well, secondary prophylaxis is prophylaxis that's given really after an individual has already experienced, for instance, the onset of frequent episodes of joint bleeding, or has undergone a major surgical procedure, and then requires therapy to prevent bleeding after that procedure. Primary prophylaxis is the entity that describes administration of clotting factor to young children.
And the difference in advantages, disadvantages between long-term, rather episodic treatment versus prophylaxis, is there a difference here?
Well, again, for children, the joint outcome studies showed that children who were treated with a prophylactic regimen of recombinant clotting factor VIII concentrate had a 6-fold lessened frequency of hemophilic joint bleeds than children who were managed with an enhanced episodic administration.
Well, that's dramatic.
It is, it is.
And it must have a long-term impact, obviously, on the joints and everything else.
It does. The individuals who have been doing primary prophylaxis for the longest are really the Swedish. And so they've been doing this since the 70s, and they have data that's now decades rich that shows better outcomes in terms of physical activity, mobility, participation in sports, quality of life, function. And that's, I think, where we want all of our patients with hemophilia to get to.
And are there some agents that last longer, some are shorter acting? Is there a spectrum out there?
Well, within the current sort of gamut of available therapies, which include plasma-derived as well as recombinant replacement factor VIII or factor IX proteins, there are subtle differences, but they pretty much have similar half-lives. Phase 3 clinical trials have now been completed for some longer acting factor VIII and factor IX products that will hopefully be able to extend time between infusions. So, for instance, a patient with hemophilia B may be able to successfully infuse for primary prophylaxis maybe once a week, maybe once every other week.